Well, one of the issues that, of course, is of major concern for all Canadians is access to healthcare. I've been in practice for over 30 years, and I can truly tell you that I never seen the healthcare system in such a crisis as we have today. 15% of the population of Canada do not have access to primary care, and our emergency rooms are really bursting, and we have this terrible overcapacity on our tertiary care centers. When we look at expenditures of healthcare in Canada, the country is spending about $400 billion in healthcare. And when we look at where healthcare is spent, we have a centralized system with a lot of healthcare is spent in the hospitals, and everybody goes to the hospitals and the tertiary care centers. That is why we have this big issue of over capacity. But the outcomes are really poor. These are the headlines on a daily basis, and this occurs in every province, of course, including Saskatchewan, but really the rest of Canada. One of the things that is really important for us in Saskatchewan is this issue of northern communities. And if you draw a line on the map of Canada, individuals in these northern communities have really a hard time accessing healthcare, not only elective healthcare, but also emergency healthcare, situations of life and death. I've shown this slide to many groups, and people tell me that this line should be drawn even further south. But I'll be talking mainly about Saskatchewan. 30% of the population of Saskatchewan is rural. We have a big territorial extension, the size of France, and 1.2 million people that are scattered. I just want to share with you this statistic, which is really gives you a sense of the inefficiency of the system. The Indigenous population of Saskatchewan is 187,885 people, but Indigenous Service Canada spends $116 million in transporting Indigenous patients from one place to another. That is not providing them any health care. That is just moving a patient from one place to another, and sometimes this transportation is not really timely. The outcomes are really sad. This is the preventable mortality in northern Saskatchewan versus southern Saskatchewan. As you can see, it is double preventable mortality in the north. So if you live in the north, you have twice the rate of mortality of preventable causes. And look at these statistics about TB. TB in northern Saskatchewan is several times the TB rate in the rest of Saskatchewan. So these indigenous populations and remote populations really have poor access to healthcare. And that has been one of the focus of the Virtual Health Hub. First, a philosophical shift from a centralized healthcare system to a distributed healthcare system, and then the ethical imperative to provide healthcare to the most vulnerable and underserved populations in the country, which are mainly the Indigenous populations in Canada. So we've been working over the past decade or so in really bringing the healthcare system to the patient wherever that patient is, regardless of the geographical location. For example, an individual with chest pain that may come to a remote nursing station in the north, can that individual be seen by an emergency physician in a rural hospital or a specialist in a tertiary care hospital, and do a comprehensive assessment of that patient and determine if that individual can be treated and managed in their own community, or it needs to be triaged to a more centralized healthcare system. Over the many years, we've been trying a lot of technologies across Saskatchewan, but what we learned over this past decade of working in virtual care is that it is not about the technology, because as you know, technology continues to evolve and change. It is about these systemic barriers that are challenges to deploy digital solutions in a sustainable fashion, in an effective way to these populations. So we've been focusing on these barriers and develop AI tools that allow us to deploy these systems in a rational and sustainable fashion in these communities. So we have developed a virtual health hub artificial intelligence ecosystem who could be a blueprint for a scalable virtual care across the country. So we've developed a suite of AI tools that will allow us really the support of the planning of implementation and scaling up virtual care solutions in an evidence-based and data-driven way. And I'm going to give you a few examples of these tools that we've developed. So we, for example, we developed a site qualifying checklist that allow us to truly understand the clinical needs of the community. I'll walk you through the way we do the assessment before we deploy any digital solution. We do a deep clinical needs assessment in the community where we try to understand what are the clinical priorities, what are the clinical gaps, what do they actually need in that specific community. Then we do a technological readiness assessment. Do they have a Wi-Fi? Do they have cell communication? Who manage their telecommunications infrastructure and what type of technology they can support? And then this very important human resource and workflow assessment. Do they have nurses? Do they have doctors? What is their clinical workflow? What type of technology can be incorporated into this workflow to be effective and to be sustainable? So I'm just gonna share with you a couple of tools. We have developed an AI collaborator called Echo, and this tool is a community profile AI tool called Scope. So when I came to Saskatchewan about 10 years ago from Halifax, as Aaron say, I'm a neurosurgeon. My first time on call here in the hospital, one of my residents got a call from a northern community in Saskatchewan with a patient with a head injury. The first thing that the resident asked the clinician that was referring the patient is, what does the CT scan show? Really no idea that that community doesn't have CT, they don't have x-rays, they only have nurses. We really navigate blindly when we look at these communities across Saskatchewan. And the same thing happened in Nova Scotia when I was there. So Scope will give you an immediate real-time profile of the community. For example, this community is called Hatchet Lake. It also has a different name, Wollaston Lake. The first thing that Scope will give you is that it is 10 hours and 46 minutes to the nearest referral center, which is in Prince Albert. It provides you the context to make a clinical decision. But Scope can give you even more. It can give you, for example, the demographics of that community, 1,584 people. 42% of the population is less than 20 years old. The northern and indigenous populations are very young. They're growing at 4 times the rate in the rest of Canada. And then, the prevalent diseases, issues of dependency, and even food security. So it gives the clinician this context that allows them to make a rational decision about the management of that patient or the triaging of that patient. A second tool is called Select. This is the technology assessment AI tool. So as you know, the number of virtual care technologies continue to increase around the world. We have thousands of technologies. So what type of technology do you choose for a specific clinical application? In this case, wound care. And I'll be talking about wound care a little bit later. So Select allow us to compare different technologies. For example, this is a wearable technology. This is a card. Select can give us the sophistication of the video systems, the resolution, the telestration, the telecommunications. It really helps us select the appropriate tool for that community, for that specific clinical application. So I'm going to give you an example, a practical example of how we use these tools to provide care. This community in northern Saskatchewan here is called Pelican Narrows. When we did the assessment on Pelican Narrows, it was clear that the number one priority was the healthcare of young children, newborns to toddlers, and children that were acutely ill. You can imagine a child with respiratory tract infection that is getting blue. The mom takes it to the remote nursing station. The first thing that the nurses do is they just run to the phone and call for transportation. Um, in some of these transportation may not arrive on time. A lot of babies have died in the north because transportation has not arrived. And as you know, it's very difficult to take care of a baby, intubator, or even put in an IV. And what it does, it really forces the healthcare workers, in this case nurses, in impossible situations. Sometimes they need to practice beyond their scope of practice because they have a life and death situation. And of course, if there's a bad outcome, the community will blame them. This is Dr. Tanya Hall, who is the head of our pediatric intensive care unit here in Saskatoon. And this is her control station of our remote presence robotic system. With this system, she can not only see the patient, you can examine the patient, listen to their heart, to their lungs, do an electrocardiogram, blood work, urine analysis. There's a lot of peripheral devices that are connected to this system. So we did a study where we compared Pelican Arrows, so where we deployed the robotic system, with a control community, which was basically in the rough geographical location, as well as the same size. The first thing that that study shows is that the CTAS scores, which of course reflect the acuity of the patient, were really similar in both communities. But look at the transportation rate. 100% of the children in the control community were flown to Saskatoon. And that makes sense because if you're the physician talking to the nurse on the other side and the nurse says this patient is really sick, you're going to say send it. When we look at the robotic community, only 30% of the patients were transported. 63% of these children were successfully treated and managed in their own community. And we followed these children for a few months, and none of them needed to be transported to Saskatoon. But even if you don't need to be transported, if you arrive in Saskatoon in the plane, they don't send you back into the plane to the community. It takes you 5 days to go home. So when we did the cost analysis of this, one of these robots at that time was $70,000. Every time we sent the plane was $10,000. We avoided 24 transports. It was about $240,000, plus the savings in the hospital beds of the children that didn't need to be admitted. So in a year, we save about $360,000. So this was a pivotal study that showed three things: that we could successfully manage acutely ill children in their own community with good outcomes, truly at the fraction of a cost. Uh, I'm now going to give you a couple more examples of what we call targeted digital solutions for the needs of these specific communities. These are the rates of lower limb amputation in Saskatchewan. Saskatchewan has the highest rate of lower limb amputations in the country. These are the indigenous populations, and this is the regular populations. So indigenous people are losing their legs at a higher rate than the rest of the population. And 80% of these amputations are preventable, 76% are due to diabetes. The reason is that, we have a hard time treating and following up diabetic ulcers. They continue to deteriorate in the north until the only option is an amputation. So we deploy a wearable device where this nurse is using this system that has high resolution cameras. She has a screen where she can see the clinician, in this case is a vascular surgeon. She's really the arms and the eyes of the clinician. And we deploy this for wound care in one of the northern communities to really be able to not only educate the nurses in the north, but to mentor them and provide them support in treating diabetic ulcers and decreasing the rate of amputations of the indigenous populations. Not only we've done that, but really we have developed the clinical pathways. In this case, this is a hybrid pathway that combines both in-person and virtual care. We understand the journey of the patient and how they are treated and when they are discharged. Maybe a second example that I will give you is the rate of TB in children. As you know, as I told you before, the rate of TB in northern Saskatchewan is really high. We have TB outbreaks. One of the reasons and one of the barriers of treating TB in the north is the lack of chest x-rays. Because as you know, you need technologies, you need an x-ray machine, and a lot of these communities don't have that. So what we've deployed is a digital AI x-ray system that has really low radiation. And we got exception from the Ministry of Labor and Safety to train an assistant on the other side. And I'll talk to you about these assistants to be able to work with the technologies in a centralized location in Saskatoon. We have the technology to be able to control the x-ray machine all the way from Saskatoon, and the assistant only helps with the positioning of the patient, but really the technologies in Saskatoon are in control of the examination. One of the other things that we're, of course, using is AI for the detection of TB. Of course, our radiologists review all the x-rays, but this is a part of the AI applications where the detection of TB is 97% accurate. We are also testing this AI system that allow us to do an in-depth analysis of the sound of a cough, and that can be correlated with specific conditions. So the way this works is that the patient coughs into the microphone of the cell phone, and AI then analyzes the cough and can give you at least a preliminary diagnosis. So you can imagine how useful this tool could be in screening for TB in low resource populations, not only, of course, in Canada, but globally. So there's a couple of examples of how AI is coming into clinical work on these specific diseases. Scott is going to talk to you about our telerobotic ultrasound program. Just suffice to say that we have a number of locations across Saskatchewan. We're truly world leaders on this. We have the largest experience in telerobotic ultrasonography in the world, and we just opened a center of excellence for robotic ultrasonography here in Saskatoon with our partners in France. So after this decade of working with virtual healthcare solutions, we have come to the conclusion that a centralized virtual health hub could be a model for the future on healthcare delivery, where we can do remote patient monitoring, remote clinical assessment, emergency triage, remote mental health care, remote pharmacy and physiotherapy, and remote diagnostic imaging. And this is where the idea of the virtual health hub came about. And this is the virtual health hub that is being built in the Whitecap Dakota First Nation, which is about 20 minutes of Saskatoon. This is a fully funded project by the government of Canada and the government of Saskatchewan. 70% of the funding has come from Canada and 30% of the funding from Saskatchewan. We have had a lot of support, not only financially, but politically. This is, of course, our former Prime Minister when he was visiting the hub. This is the Premier of Saskatchewan, Premier Mo. And this is Chief Darcy Bear, who's the Chief of Whitecap and who is the Chair of the Board of Directors of the Virtual Health Hub. So not only we're building the building and putting together the team, but we're building a VHH virtual care ecosystem, which is a platform of communication that will allow the clinician to be able to assess these patients in remote locations. The clinician viewer, which is this platform, has three components. The clinician viewer, which is the portal for the clinician, a command center that integrates multimodality data, PACS, imaging, EMR, pharmacy, laboratory, real-time audiovisual communication, peripheral devices, even the weather and the census of the hospitals in Saskatchewan. And the Facility Connect, which is the portal for the facility to connect to the clinician and being integrated by the command center. The command center will be the core of our new building. This is a NASA type of command center that will integrate this multimodality data. Maybe the last thing that I want to share with you is this program that has been supported. We have a large grant from the CIHR building this mobile imaging diagnostic unit, which will have a portable head MRI, portable CT, digital X-ray, and robotic ultrasonography. But the innovation is not really putting these machines in a truck. The real innovation is that the technologies that will be operating these machines will be remote. There will be a remote imaging diagnostic unit in the virtual health hub. We have now a lot of experience with remote diagnostic imaging. And as you know, this is really another bottleneck for the diagnostic imaging, as there is not enough technologies that will be able to man. There's a lot of, for example, CT scans in Saskatchewan, in many communities, that only function a part of the time because they don't have enough technologies to really function at full capacity. But one of the things that you may ask is, who's going to be with the patient? So this is another of the innovations. We're training the virtual healthcare technologies. These are individuals that come from the communities, the indigenous communities in the north, that are being trained to use these technologies and that are part of a team, of the clinical team that provides care to that patient. We're training these individuals at the Saskatchewan Indian Institute of Technology. We're training the X-rays and ultrasound technologies at the Saskatchewan Polytechnic, and the medical students and the physician assistants at the University of Saskatchewan. This is the first graduating cohort of the virtual healthcare technologies. It's a 19-week program of these individuals that have come from the different communities in the north of Saskatchewan and have gone back to work with them. So the model is that we will be able to provide care in your home, in the clinic, in the home hospital. This individual is looking at this wound, but I'm really the one that assessing the wound. The healthcare teams of the future are not only physicians and nurses, they are systems engineers, robotic engineers, experts in AI, experts in computer, and of course the next collaborators are AI collaborators and robotic systems. So I'll maybe just stop here to showing you a picture of the sky in Saskatchewan in the summer. When I came to Saskatchewan about 10 years ago, they told me that the sky was very big, and indeed it's big in Saskatchewan. And the reason I'm showing you this picture is because I'm optimistic about the future. I feel that if we use technology in the right way, we will be able to narrow the gap of inequity in healthcare delivery, not only in Saskatchewan and Canada, but globally. And I feel that really the sky is the limit here. And of course, the use of AI in carefully ways. And maybe this is a time for to ask Scott to talk about AI and its applications in diagnostic imaging.